Okay, good evening, everybody. My name is Dr. Gokul. I'm a senior resident in psychiatry at NIMHANS. So today in the masterclass on mental health awareness series, we'll have a class on suicide and attempted suicide, public health menace by Dr. Senthil Kumar Reddy. Dr. Senthil is a professor and head of the emergency psychiatry and acute care services in NIMHANS. And with more than 20 years of experience, he graduated in NIMHANS in 2003 and subsequently worked for 6 years in Australia as a consultant psychiatrist and lecturer, and has been a faculty at NIMHANS since 2010. Dr. Reddy was a technical committee member of the National Suicide Prevention Strategy by the Government of India 2022. He has been proactively involved in suicide prevention teaching, training, and research over the past 15 years, and is the current lead of the NIMHANS Gatekeeper Training Program, which commenced 10 years ago. Without further ado, I'll invite Sir to start this class.
Thank you so much for that, Dr. Gokul. At the outset, I would probably like to thank all the coordinators of the CAHO program and the office bearers as well. It's indeed a pleasure for me, to be able to participate in this and share my experiences and understanding of this particular complex issue. And once again, I'd like to convey my heartfelt thanks for considering me for the same, and hopefully, this today's discussion that we have would be helpful to all. And let's probably go ahead without any further ado. Would that be fine? As was already pointed out, this is from the Masterclass series on mental health awareness being organized by CAHO, and today's topic is suicide and attempted suicide, public health menace. What's the topic? And I just thought I'd just throw it out and probably say and wonder whether it should be a public health menace or a challenge. So Dr. Gokul's already introduced me, so without further ado, we'll just go ahead. So just today's outline of the presentation and discussion would be around the current construct of suicidality and suicide attempt, particularly its burden, across the world and in India. Suicide models, what are the current understandings of these current models of suicide? What are the barriers to suicide prevention, particularly stigma, myths, and misconceptions? And what is the WHO, the World Health Organization, advocating in the context of, preventing suicide, and what are the approaches to adopt? And what are the sort of national level programs that are, already set up and running across the world, and how that applies to our context in the Indian setting, particularly with, the evolving health system policies and programs, as well as the resources within our own country. And, whether these align with India's strategy, with the ongoing initiatives, and what could be the best way forward from here. So again, my question to all the attendees today is, as I said, is it a menace or a challenge? Would we consider non-communicable diseases like hypertension, diabetes, obesity, metabolic disorders, coronary vascular disease a menace or a challenge? The reason I'm highlighting this, particular, making it more also like a debate, is whether we would be able to, whilst we might be able to state that hypertension is objectively measurable, or diabetes can be diagnosed with a test, etc. But would these be attributable to one single cause? Would it be attributable to that person? Of all these disorders, can they be singled out as, the one single cause can be identified? Or is it, and also more so, once these disorders are identified in a person, hypertension, diabetes, obesity, metabolic syndromes, coronary vascular disease, etc., are these all treatable, and are they curable? And does everyone respond equally in a similar way? And whether indeed the outcomes in these disorders are, equally good across, and whether, it's because of our understanding of all these disorders, are they, managed in a way where morbidity and mortality has come down significantly? I wonder, and I think, it's about everyone reflecting on that more than anything else. So I would probably move on to what the current understanding and construct of suicidality is. Suicidality is something, or suicide and suicide attempts, which fall under the rubric of suicidality, essentially are, things that have been there time immemorial. They're colored, our understanding, our constructs are obviously, colored by society, by history, by our past, by culture, and a variety of different factors, not just necessarily in our country, but across the world. But what has been come to be understood now more recently is that broadly, this is the consensus across the world, that there is a concept of self-harm. And depending on the outcome, whether it's the death, a person harms themselves with an intention to die, or death is not intended, they're classified as, suicidality across the spectrum. So someone could be experiencing, thoughts of death, like passively dying in the context of some difficulties that they're encountering. For example, I might as well be dead rather than, struggling like this, or specifically thinking, I should die, which becomes suicidal ideation. And if suicidal ideation and plan, which is the next level of severity, is where a person starts actively thinking about possible methods in which they may wish to end their life. And ultimately that translates and at times culminates in an attempt. Importantly, these stages of suicidality, which is all more like a continuum, across for an individual, particularly within an individual itself, they go back and forth. So it's not that someone at the outset makes the decision to end their lives and goes ahead and successfully does so. Most people are actually quite unsure of that, and struggling with and contemplating that. And there's a lot of aspects to that, and we'll discuss that further. So just to help everyone get a perspective, suicidality is much, much more broader than just suicide and suicide attempts, and includes ideational and plans as well as death wishes. Now, just to give a perspective on where India stands and what's happening around the world, this is from the WHO, as per the data from 2019. And as you can see, the darker the color, the rates of suicide are the higher per lakh population in among both genders. And if you notice India, which is orange in color, it's not maroon, and orange signifies a rate of 10 to around 15 per lakh people. So it's clearly in the higher bracket in the world. And there are a few countries like Australia and parts of Africa and the entire United States and Canada that has similar rates as India. I would like to probably mention as to why I'm bringing this, because there are also interesting factors or aspects of this distribution that vary when it comes to India vis-a-vis the world. So if you look at another very troubling perspective, is the fact that these are as per the age, the rates of suicide, and the income level of the country, which is highlighted by orange, and which is low and middle income, and the dark blue is the high income countries. And if you notice, as per the age, from it progressively increases between the ages of 15 to almost 35, 40, and then stays static and then drops. But if you notice, for each age bracket, the majority of the suicides that occur across the world are attributable or contributed by the low and middle income countries, where India falls as well. And if you look at the top causes of death worldwide, between for both genders or even between the genders, you would find that suicide ranks either the third or the fourth leading cause of death in this particularly in this age group of 15 to 29. So that's a very, very worrisome trend, because it's obviously the younger age group that's significantly affected, and it is among the leading causes, which is again very, very not very well understood amongst the world, that indeed suicide contributes to such a significant level of mortality and death. So if you look at specifically to genders, and this is an aspect that I'd like to highlight, if you look at the males, you'll again notice that again India has a similar color code as what I had shown previously of both genders, that is. It's orange, it's 10 to 15 per lakh population. And a large number of other countries, particularly the developed countries like the US and Canada and most parts of Europe, have rates much greater. That means that males the rates of suicides amongst males is much greater in these countries as compared to India. When you look at women, it becomes even more fascinating because with India, if you notice, is in orange again, but it's probably got the highest rates of suicides among women. So what does this tell us? It tells us basically that the rate of suicide, particularly among men and women in India, is almost similar. So it sort of is against that misconception that, men are likely to be more at greater risk for suicide. And that is derived from basically, literature and research from the developed parts of the world. But this all are the maps that I've shown you from the data from the World Health Organization. So, and if you look at the ratios, like I said, it's basically comparable. We are in a light yellow, the country of India, and it basically suggests that males and females, the likelihood of risk of suicide is equal between these two, between males and females. And so if you look at the National Crime Records Bureau data and how the distribution is within our own country, when we come to our country, we would find that, the highest rates are in the southern states like Kerala, Tamil Nadu, the next as well as Telangana. And if you look at even the second highest rates, which is a large part of the middle and the lower part of the country, apart from a few states in the northeast, suggests that there is a variable distribution across the country, and a large proportion of suicides are attributable to the middle and southern parts of the country. Now, so what is the relationship between the issue of India and the rest of the world when it comes to suicide? Although we constitute 18% of the world's population, and 42% of our own population is amongst this age group of 50 to 39 that I was pointing out, our contribution to deaths, global suicide deaths, one of each three women who die by suicide across the world is from India, and one of four men is from India, suggesting a 33% rate of suicide, contribution of India amongst women and 25% contribution amongst men. And like I'd earlier mentioned, the rate is almost the same between the two when it comes to the context of the Indian setting. Now, within the Indian setting for this age group of 15 to 39 is the leading cause of suicide. And it exceeds maternal mortality among women and road traffic accidents amongst men. So that's very, very worrisome, because this is the most productive, this is the next generation, this is the age group of people who are going to take the country forward. So if we're losing a large proportion of our young population to suicide, it is indeed very, very worrisome for our country. And the rates, like I said, are higher than the global average in India. And interestingly, as per what I had shown you, as per the National Crime Records Bureau data, the states that had a better socio-demographic profile seem to have higher rates, unlike what has been observed in other parts of the world, where low socioeconomic issues are known to be associated with a greater risk for suicide. This is just a pie chart of the National Crime Records Bureau about what they state up the potential causes. But I would not say that these are actually the causes, but these pertain to possibly, most likely, triggers that have precipitated an event or suicide death. And if you look at it, family problems constitute a large proportion of it, almost 1/3 of it. And illnesses, including, of various types, constitute close to 20%. So drug and alcohol, although listed separately, is also a disorder, as you may have come to understand through this mental health awareness series. And if you notice that, it's almost like, again, that constitutes another 1/3 of the population, or the deaths attributable. So the next question comes, are suicide attempts and suicidality different when it comes to suicide? Yes, in a way, and no, in a way. So like I said, it's already on a continuum. But what is concerning is that the number of attempts that occur as per the WHO is 10 to 20 times greater than the number of suicides across the world, although the exact figures are not known. And there is still some debate about whether these are indeed two different sets of vulnerable groups, or indeed whether they constitute, a similar, spectrum of individuals across a continuum. And because of the limited evidence that is available on this particular aspect, the issue of suicidality and suicide attempts, because this data is not really accurately captured in any part of the world, including India, it becomes very hard to actually work out what could be the exact proportion, but there are estimates driven by certain studies, including in India, that possibly allude to what could be the, the burden that suicide attempts pose as well. The main issue is that because there is a lack of data, there is a certain ambiguity between whether it's people with, who end their lives to suicide vis-a-vis who attempt suicide, and whether they're indeed different populations or one similar vulnerable group. There is also a little bit of confusion, or rather challenges it poses in the context of evolving effective suicide prevention strategies, which is ultimately the focus of any such issue wherein the death and mortality is attributable in such high rates. So the National Mental Health Survey of India, which was conducted in 2015-16 by Menace, actually indicated that suicidality, and this is not suicide, this is not death by suicide, but just attempts or ideation or plans, like I had mentioned, was approximately 5% of the entire sample size. So this was extrapolated to suggest that possibly 5% of India's population experiences thoughts of death, suicide, or have attempted suicide. And high suicidality, which is wherein they're very imminently likely to attempt suicide, was almost 1% of the population. So we can only imagine the numbers that we're dealing with and the magnitude of the problem in India. So for each suicide in India, there are approximately 200 people who had suicidality, and 15 had attempted suicide. And as the map showed of India, it varies across age, gender, and regions, as well as the states. So this is just this is a study again, which was published from the National Mental Health Survey of India itself. And this is a study published by NIMHANS, and it actually compares the suicidality, that is, people who've thought about suicide in the country, vis-a-vis the people who died by suicide in a similar way. And it actually shows the color codes. The darker the color, that is dark red and light orange, vis-a-vis blue is lower rates. And if you notice, the left side of your screen would show suicidality rates per lakh population, and the right side shows. So there is some difference, but there's also a similarity if you look at this, particularly the southern states. The rate is slightly different, but the loading is pretty much the same, whether it's suicidality or suicide. Similarly with Chhattisgarh as well. And there are discrepancies with, and Madhya Pradesh, etc., seem again very similar. So it's quite likely that there's certain parts of the country, both these groups are equally vulnerable or similar in a way. And possibly there are certain differences, and we have to try and understand that, which is yet to be determined. So what could be the basis of suicide? Now, that's another question. So a lot of people have various ideas about it based on what they've been exposed to through the media, their own understanding, what they have come to, understand from interactions. And there are obviously a lot of, again, misunderstandings, I would say, and myths and misconceptions. So a lot of people think that someone who's very weak is, someone who kills themselves, dies by suicide or attempts suicide, someone who really doesn't have the necessary capacity to handle the life's challenges, also, ends their life by suicide. But what's been through research over these last 2 decades, particularly because it's accelerated dramatically, and what science has shown clearly is that there is a neurobiological basis for suicide. So it is a complex interaction between, the immune function, the neurotransmitter systems, the stress response, and how the hormones affect the HPA axis, affects and influences that, as well as the role of lipids and neurotrophic pathways, which ultimately culminate in these regions being affected and leading to ultimately suicide. And obviously the most recent has been also a literature suggesting that there's a brain gut, the microbiome, that also actually has a role to play in contributing to vulnerability to suicide. So what is a biopsychosocial model, which is probably the universally accepted one, that there is no single cause, like with various NCDs. And there's a whole host of societal context issues, issues in the context of society, lifestyle, what we're exposed to, like the media reporting, the sense of isolation that's increasingly occurring with the technology exposure, and the lack of the change in how, we are interact with one another as a community. But there are also distal factors that are driven by epigenetic alterations. So it is an amalgamation of various aspects of genes which are influenced there. The gene modifications are influenced by adversities in early childhood, perinatal period, that leads to evolution of certain vulnerabilities in these individuals, and at times maladaptive coping styles as using substances, developing impulsivity, aggression, and having a negative mood state, and sometimes even poor planning and higher executive functions. And that culminates with some trigger, which is invariably a life event associated with some level of mood state or anxiety or distress. And that is, again, if you look at the ways the arrows line up, you'll come to understand about how that leads to thoughts of suicide or thoughts of death, or actually death indeed. So there are different models and different people have proposed it, but they pretty much are the same. And if you look at, this particular one I wish to highlight was just to help understand for everyone that there are numerous societal determinants. Some of them we may know, some of them we may not know, but there are also factors at the demographic level as well as the individual level. And all these sort of converge or interact as a complex interplay between all of this that actually ultimately leads to the outcome of suicide or a suicide attempt. And so it's very, very important for us to remember that it's not a social issue, it is not an individual level issue, but it's actually got psychological issues, there are biological vulnerabilities, and obviously there are social aspects, which all, interplay with one another in a bidirectional or a multidirectional way, I would say. This is another model. Now, I'm just trying to help understand that it's extremely complex, and this is just to help sensitize all the attendees today that, these are how, suicide has come to be understood now, which is very different from what it was, or probably large proportion of the population knows it to be. And this also looks at, this particular model actually focuses on how the ideational aspect comes, how it goes back towards, the intent increases vis-a-vis attempt occurs, vis-a-vis what can prevent it, and how people go back and forth to help give a perspective on why I had pointed out that people move between the passive death wishes to just suicidal ideation to a greater intent and then contemplating attempt. And so it becomes extremely, extremely important to understand that there are factors that also pull back people from such thoughts and experiences. And these are usually called rescue factors or protective factors. And it's about how people can correct themselves, because a proportion of people is far greater than the people who actually attempt suicide or die by suicide. So clearly there is a set of people within this group that is able to manage somehow, either with assistance and support, etc., especially like we're talking about attachment and, a close social connectedness, having support systems or access to support, and or proactively help seeking, etc. So when we look at what are the barriers, like I said, the issue is there is very limited research in the Indian context. It's still, the scope is not fully, completely understood when it comes to the whole idea of suicide attempts and suicidality. Even whatever exists, there is there's doubts about the consistency of these findings, and obviously the fact that for prevention we need human resources, which are skilled human resources, and systems in place. Now, there's most parts of the world, including India, there is a gap that exists in these areas. There's also the high stigma and extremely poor awareness, which prevents people from seeking help in a timely manner, or reaching out or asking for help, or availing of services. And also the fact that beyond healthcare, mental health care providers, there are numerous other stakeholders, and their involvement remains still at the periphery, and their involvement in effectively working on suicide prevention continues to has remained a challenge till recent times. And the fact that we are actually quickly evolving with technology, advancements in technology, and how technology is shaping the next generation, how we are all reading about what's happening with increasing use of technology, how it affects all of us, how it affects young persons, how it affects their capacity to think, plan, have problems with memory, how it isolates them, it prevents them from developing close connected relationships with their peers. And so there are numerous sets of factors. And because it's evolving so rapidly, the whole, component of whether whatever prevention strategies are being formulated and have been thought of, can they keep pace with this change that is so rapidly occurring? So coming to stigma, I'd like to highlight the fact that there is some concept of public stigma, like many people have, including most of us, when we look ourselves as belonging to a part of a community, and there are stereotypes about suicide, people who are suicidal. There's a prejudice about them, there's a judgment, and there's obviously some level of discrimination, right? And mental illness stigma coexists. There's at a personal level, because of all these societal issues, at people who actually perceive stigma, are also struggle with that. And that's why they are, and people who experienced it as well, are the ones who have actually made attempts, right? And the ones who have a lot of self-stigma are the ones who are survivors. That means who have either attempted and survived, and they have a stigma about being people who are suicidal or labeled as suicidal, or even their family members, for that matter, amongst people who've died by suicide. So there's a lot of perspectives on stigma. Now, like I said about the issues of awareness and myths and misconceptions, this is very critical, and this applies across the world, not necessarily just in India. So most of these are the most common myths, I would say, and they're all wrong. Most suicides happen suddenly without warning. Only people with mental disorders are suicidal. Someone who is suicidal is determined to die. Once someone is suicidal, she will always remain suicidal for the rest of their lives. If we talk openly about suicide, it will start to trigger it or cause it. And there is absolutely no way of identifying people who are contemplating suicide. And if they decide, well, there's nothing we can do to stop it. And if someone actually does talk about it, they're obviously just joking or wanting attention. So, it shouldn't be taken seriously and it should be ignored. And if at all someone is actually, in a crisis and possibly very likely to commit suicide or attempt suicide, then it's only mental health professionals who can help them. So these are all of them, if I would say. I'm not sure because we don't have an interactive platform here, but I would imagine that most of us who are not familiar with this background would probably have some of these constructs in our mind. But I would like to categorically state that all these statements are false. And so that's what I mean by saying that they are the myths and misconceptions. And these statements have been statements that the World Health Organization has stated are the myths and misconceptions of suicide. So it's not me, it's not this country, it's actually across the world. So what does World Health Organization propose for suicide prevention? What they have proposed is something, because it's not an issue that pertains to a single country, a single set of people, or single age group, etc. But the fact that it is a public health issue, as the topic clearly highlights. So it actually warrants a multi-layered interventional approach, which is universal, which is community-based. It captures the entire population. Selective interventions which are targeted to highly vulnerable, individuals like people with substance use disorders, people at a certain age group, like I said, young persons and adolescents, people who've lost, people with mental illnesses, because they have a greater risk for suicide, but that doesn't mean that only people with mental illnesses committed suicide, like I said, and indicated interventions. That means this is intervention specifically directed towards those people who've attempted suicide. So how do we make sure that they don't attempt suicide or die by suicide in the future? So the UN's Sustainable Developmental Goals target by 2030 is to reduce, 1/3 premature mortality from non-communicable diseases. And the prevention, treatment, and promoting mental health well-being falls within this purview. Interestingly, one of the indicators of NCDs 3.4.2 is suicide mortality rate. I'm not sure how many of you are aware, but suicide has actually been earmarked within those NCDs. And the construct Live Life has been proposed by the World Health Organization, which focuses on leadership, interventions, vision, and evaluation. Through the interventions, it means limiting access to means and lethal means of suicide, interacting with the media to ensure that there is a more constructive approach to how media reports suicides, that facilitates help seeking rather than create false and negative perceptions, or trigger copycat or the suicide contagion, as we call it. Inform the young, support the young and adolescents, the younger generation, given that they are at the greatest risk, and how we support them through their life skills training and developing life skills to handle the rest of their lives and the challenge that they are going to encounter for sure. And obviously early identification of those possible in the community or the society who are at risk, and obviously by not just identifying but also providing them management and interventions as well as follow-up and support. So this is a typical component of what is called the suicide prevention strategies that are espoused by the World Health Organization at a national level. Now, if you look at the bottom, the roots which form the foundations for effective implementation and action, there's oversight and coordination and surveillance and monitoring on one side. There is obviously about restricted access to means, media reporting, like I said, having access to healthcare and social services, training and education, that is scaling up resources, and obviously various types of interventions for those individuals who have attempted suicide. But there's also enhanced care on the right side, crisis intervention models, what happens post-prevention means post-incident of a death, creating awareness, and then addressing the stigma. So all of this sort of comes together in a tree sort of a format with multiple branches that are sort of working towards that. In the Indian context, what is slightly complicated is the fact that whilst we need all these strategies that the World Health Organization has proposed, there are resource issues. And so there's a broader scope which needs to align with whatever exists in our country, and also ensuring a more trans-sectoral and a positive mental health and well-being approach. The resource gap, just to highlight, I'm sure has gone through previously, and my colleagues would have presented. The shortage of mental health professionals is extremely accentuated. So we have there's no way that our mental health professionals in any way can directly provide care for all those who are in distress and experiencing suicidality. So the fact that there is such limited access, the paucity of the resources, it's about actually, the fact that there's primary health resources also available don't have the necessary skill sets to actually provide the necessary care. So it's about looking at ways in which we can scale this up within the existing structure. So what did India do? It created the National Mental Health Policy, and then the National Mental Health Program that's been running before 2014. Then it introduced the Mental Health Care Act. It introduced commensurate strategies, and it was only in 22 that the National Suicide Prevention Strategy came into being. So all of these in a way are interlinked and entwined, and I'll just explain that further. So the National Mental Health Policy objectives, reduce risk and incidence of suicide was one of its main objectives, apart from issues of mental health and mental illness and stigma, etc., and to increase, facilitate care access. In the Mental Health Care Act also, importantly, what it did was it decriminalized suicide, in addition to, highlighting the need for integrating mental health services into general health care. So suicide was set aside as a separate target for the National Mental Health Program as well as for the Mental Health Care Act. So it actually was not, whilst it is within the ambit of mental health care or mental health, it still separated and distinguished it specifically. And the Ayushman Bharat, which is the broad comprehensive primary mental health care program for all variety of disorders in the country, one of them, the focus is on suicide prevention. So the National Mental Health Program is, greatly advanced in the last few years, and there's, it's been now well laid out. So we have a certain resource pool that's available in terms of mental health professionals, and also, systems that are being evolved and set up as a part of the National Mental Health Program. So this sort of gives us some sort of a basis for it. Also, the fact that we've integrated and working towards integrating mental health care into primary health care itself, given that we have far more, general practitioners from various disciplines and alternative medicines, as well as frontline workers, I think, the important thing is to harness that resource base to try and prevent suicide. And that's the focus of the Government of India as well. So as all of you may very well know, and Dr. Naveen may have talked about the National Telemental Health Program, one of the key aspects of this also integrates suicide. It's like a national suicide prevention helpline. There is a single toll-free number. Anybody from any part of the country can dial that number, and they'll be linked in to a language-compatible person at 24/7 all through the year. How they do that, I'm sure, I don't know whether Dr. Naveen ever mentioned or discussed this, but essentially based on your SIM registration, like I'm registered in Karnataka. So it'll take me automatically, it'll identify that and link me either to the Telemanas cell in Karnataka. So they would either speak Kannada or English. And so that way the Telemanas program has overcome the challenge of different languages and the multilingual nature of the Indian context, and ensured that despite that, timely healthcare, including suicide prevention, active care provision can be done within a single number window. So what has facilitated the National Suicide Prevention Strategy and the focus on that more? A favorable ecosystem, like I said, has been evolved because of how the government has taken this forward, a lot of advocacy by relevant stakeholders. There's a lot of active judicial oversight, NGOs and PPP, public-private partnerships have enhanced that cooperation, and obviously the various other aspects that I had just discussed. Importantly, technology integration and also a lot of parliamentary and legislative, driven inquiries have, furthered sort of escalated the culmination of this developing and being launched in 2022 by the Ministry of Health and Family Welfare. This is an open source document. Anybody and everybody can. It's a very comprehensive one and very well highlights all the aspects. So interestingly, I just bring you back to the WHO website, and this is from the website, and what is the issue of suicide prevention that's been historically evolved and what it applies to currently in the context with the Indian setting. So as of 2023, although suicide prevention guidelines started the UN proposed in 1996, as early as that, only by 2023, there are only 49 countries that have a standalone national suicide prevention strategy. Importantly, if you look at the right side, bottommost corner, India is actually one of those countries. So it's really indeed very, heartening to find that we're amongst the numerous countries in the world, amongst just the 49 that have a national, separate standalone suicide prevention strategy. And this is again available on the website. It is India's suicide prevention strategies listed officially on it, and it again has a download access and content, and clearly has validated India's efforts towards suicide prevention. So the suicide prevention strategy in India basically adopts this, sort of the REDS path, as it calls, reinforcing leadership, partnerships, capacity, enhancing the services, developing resilience within the community and societal support, and strengthening surveillance and evidence generation. So it adopts these same approaches to reduce access to easy care, strengthen healthcare systems, sensitization of the media, and strengthen the suicide surveillance. So its objective is the targets are within next 3 years, we have to set up a system, structured surveillance mechanism to document how many attempts, deaths are occurring, ensure that all the other active components, ancillary components are well established within 5 years, and integrating mental well-being into educational institute over the next 8 years. And so that would require a lot of leadership from some centers of excellence, including NIMHANS, collaboration between various stakeholders, and then the transsectoral, because it's not just about mental health or health, it is also about education, it is about women and child development, it is about a variety of different ministries, that in their standalone right have aspects to them that contribute to vulnerability and risk to suicide. So the whole of government approach actually, like I said, involves this universal prevention, selective and indicated, and it sort of cross-cuts across everywhere. And so it's important that we keeping this in mind, the National Suicide Prevention Strategy was formed, and this is part of our strategy, a multi-sectoral approach, and involves everybody, all sorts of individuals from different backgrounds, including KAHO. And I'm really happy to see, the fact that KAHO has been, very, very keen to also get involved. So, and I think it's very important to understand, that we are all sort of working together towards this. So this is the sort of ideal approach or the optimal approach, and this is the one that we in our countries adopted. Sort of not just one tree, but many trees, because that's the way it's going to work. It offers a greater coverage, greater broader base, and it consolidates the entire suicide prevention program for the. In NIMHANS, what we've been doing is called what's a gatekeeper training program for suicide prevention, which is primarily empowering community members in early identification of individuals at risk, and linking them with resources and sources, and facilitating and encouraging them to seek help. So they are not mental health care providers, they're lay people, they come from different backgrounds. We have trained people from across different sectors, and all of them have been trained, and we call it the LOCT because it's the local gatekeeper training program. Basically these individuals are gatekeepers in the society, and we call it the locked because it's almost like a lock. You prevent a person from also stepping over to the other side of life, beyond life rather. So like I said, we've just covered a variety of different organizations and students and etc. And we've just created a wide network base, and hopefully more and more of these, this network would keep expanding as well through our collaboration with various other service providers. So what's the way forward? What we need to do is figure out acceptable strategies to ensure effectiveness, create data registry systems so that we can ensure what we are doing is correct, and we have to modify, course correct, change, and redirect our, efforts in certain parts. We have to do that. We, ensure that we use technology in a manner that permits us to, reach out to the farthest of corners of the country, and also use the same technology as Manas has done to permit people to seek care in privacy, with ease, without having to actually walk long distance or travel long distances to seek specialized care. And obviously, combine that with, advancing research to better understand this construct of suicidality and suicide, thereby helping us further, prevent suicide in the future. These are just the other countries, and this is just to monitor this. I just put this slide up to help understand what are the various countries, about how they've progressed, examples, and the indicators. So how they have tried to evaluate their existing programs, and how India would be adopting the similar approach is what is planned for the future. So this is the International Association of Suicide Prevention's, sort of last few years of, message about creating hope through action. Thank you so much.
Thank you, sir, for this presentation. I think now we have around 10 minutes time for the Q&A. First, we'll go through the comments first. She's asked a question which is not clear for us. What is postvention in preventive measure?
Yeah, so I think what Garima ma'am is trying to probably inquire is, what does postvention mean in the context of prevention? So essentially, what has been come to be understood is that after an incident, wherein, say, for example, a person attempts suicide but does not die by suicide, there is a greater risk of reattempt or death by suicide in that individual, particularly within the first 24 months. So postvention are specific strategies that are, sort of focusing on these individuals to ensure that they are not, they are less likely to make a reattempt or die by suicide in the near future. And this is done through various, innovative strategies. One study, actually, what they did was actually they sent out a brief text to that person periodically, rather than ask them to just come for follow-up or check up with the local mental health care provider, or even come to the hospital. They would just check, drop a, a message about how you, hope you're well, we are available if there's anything you need to talk about. And they found that this particular group that received these texts, actually the frequency of attempts was much lower. So it could be a very simple thing like that. There's also much more intensive postvention strategies that are in place, particularly for, sort of people affected by death, a suicide death. Typically, this is, for example, in schools and in communities and family members. The likelihood, as you may have read also, is that often what happens is when one person dies by suicide, an immediate near and dear one also ends their life. So the greatest distress and experience of loss, etc., and the risk for the person who's lost their life to suicide are the near and dear ones. and they immediately affected individuals. And those people warrant specific strategies to try and help them process the loss, grief, go through the grief process. And that's something that's typically done by mental health professionals. And it's also done through group-based activities, and where survivors, there are groups of survivors who work together and support these individuals in this period of crisis and extreme pain.
So Mohan R has asked, is post-traumatic stress disorder maybe one of the cause for suicidal ideas? If it's one, if it's one of
Yeah. So Mr. Mohan, you're sort of, I would say, partly right, because post-traumatic stress disorder does increase the risk of suicide, but it is not a cause per se for suicide. I would like to highlight that. It is likely to increase risk as various other conditions, various mental health disorders do. They increase, but it doesn't mean that every person who suffers from post-traumatic stress disorder is going to end their life by suicide or make a suicide attempt. A large proportion don't. One of the things is that it's about managing the primary underlying condition in this case. So it would be post-traumatic stress that needs to be managed effectively through appropriate professionals to try and help them overcome the trauma, and thereby, not really experience post-traumatic symptoms of post-traumatic stress disorder.
So Devanti has asked, how do you provide solution for attempts due to economic crisis?
Yes, yeah, that's a very good question, and I think that's a very important area to cover as well and understand. So, like I had mentioned, the models that I had actually shown, if you were to probably recollect, otherwise I can always go back. It's important to remember that everybody in an economic crisis doesn't make an attempt or die by suicide. There is a certain set only of people. So a lot of people face economic hardship, economic setback, losses that increases their risk for suicide, but everybody doesn't attempt or think about suicide. So there are clearly this subset of individuals within this wherein they have a multitude of other variables that, starting from their early childhood development, etc., that leads to that. So now the solution is not about alleviating their financial crisis or the economic stress, because the focus may be right now, the issue right now might be finances. Later on for this person, it could be a relationship crisis. Later on, it could be some sort of other professional or, expectational mismatch crisis as well. So I think what is important to understand is that this person is vulnerable, and, in the context of hardships, any sort of setback, tries to revert to the default systems of, the way of handling, their distress. So I'll just take you back a slide to help everyone understand what I'm talking about, and I'll just quickly scroll back to that model so that everyone also feels more understanding of what I'm saying. So here is what we are talking about. So here is wherein the economic crisis is not that you would give the person money and relieve them of their distress, immediate distress. But, in the sense of, if you look at the ideation and the hopelessness that the person is perceiving in the context of, having an economic issue. But the fact that the person should be willing to seek help, support, in the context of what they are thinking because of their financial loss, and what are the inevitability of the fact that there's nothing to live for, and how they can actually, whether they have support systems, they have attachments to family. So a lot of people who we've encountered have actually said that what's held me back is my children, from acting on these thoughts. I can never do this to my children. And sometimes, so there are various other things that hold people back and prevent them from taking that step. And often most people who attempt, when we talk to them, they're extremely regretful, and they're extremely, distressed, because they actually don't want to end their lives. The natural human instinct is to survive. It is not to die. And that reflex has to be, to override that natural human instinct takes a lot of effort and, overwhelming, conviction, which is not often present in most of the people when they're encountering such a thing.
Thank you, sir. So, Ananya asks, what are the implications of trauma and adverse childhood experience on suicidal behavior?
Yes. So again, a very, very interesting question. And again, what is very important to understand is that early childhood trauma, has a complex way in which it impacts and influences, future risk for suicide. So essentially, it's very well known and recognized now that adverse childhood experiences of any type, whether it's deprivation, emotional abuse, physical abuse, other traumatic experiences, having lived through a disaster, having lived through, war, etc. All these traumatic things, particularly in childhood, create, some. They don't actually. It's not just the psychological aspect of being exposed to such traumatic, events or childhood experiences, but it's also the fact that it actually physiologically changes the body's regulatory systems. So the chronic stress that I had alluded to in the neurobiology, the chronic stress starts, kicking in, and the stress response gets aberrant, which influences the HPA axis, which influences various other neurotransmitters, which the neurotransmitter starts getting dysregulated. The networks in the brain are not optimally working in the manner that they are. So automatically, the person's ability to think clearly, plan, focus, stop themselves, like a lot of us do. When we think about anything, we plan, before we take the step forward, right? So a lot of those things get affected, and a lot of it is affected by the genetic changes or the epigenetic genetic changes that occur in the context of that exposure of trauma, early childhood experiences. And so all of that culminates in a vulnerability eventually. Hope I could explain that. It's very complicated. It's all very intertwined, and I hope I could give some semblance of a simpler answer to that.
Yes, sir. So, Devanti has asked, people killing their children and committing suicide, are they sick for a long time or is it?
Yeah, so this aspect has not been very clearly delineated, because this is a very complex issue again, because nobody's alive to recount anything. So often it's not very clear as to what the motivations are. But again, we have encountered people who have actually, in their extreme state of despair and hopelessness, most often this would occur in the context of very severe mental illness, not severe mental illnesses in that sense, severe depression for that matter, wherein they believe that the only way that they will be able to, help, themselves and their family from the suffering is to end everybody's suffering. So often these are driven by these faulty thoughts in the context of their mood state and their circumstances, wherein they think that it is to relieve everybody's pain, that they would be better off if they are not alive. So they're not intending to kill their children, with the intent to kill them, but it's actually to relieve, make them, make the children be in a better place, in a way, assist, helping them is what is, the process in their mind often. This is something that we have, heard verbatim from survivors who've unfortunately done this. And then when they've attempted suicide for some odd reason, they've been survived it. And they're very, distressed by the idea of having survived it, but at the same time give these explanations, and these are things that have been still sort of being, explored.
So, I think that kind of
Yes.
answers to the next question.
Floods, landslides, yeah. There is a disaster management program. There is, in fact, a Center for Psychosocial Disaster Management in NIMHANS itself. It's a department rather, and it's actually been attending to a lot of disasters across the country. So, from the tsunami times, our department has actually stayed in the Andamans. Various faculty and other people have stayed there, and when it was completely destroyed in the tsunami, and spent many months, different people kept going by turns to attend to the psychological needs. When the Uttarakhand disaster happened, again, the same thing was done. It was done in the earthquake times as well in Maharashtra. So this is something that's a very, it's a community-driven, level, destruction that has occurred. So a lot of it is about grief, loss, survivor guilt, There's a lot of aspects to it. And often what psychosocial disaster management does is actually focuses on the mental health aspects of these individuals and hand-holding them through the process of, questions like, why am I alive? What deserves me to live? And ensuring that they are able to pull through that pain.
So I think like we have time for one or two questions. Sri Lakshmi has asked, most of the female have a suicidal tendencies after pregnancy. Is that also kind of a trauma?
Okay, so what you're alluding to possibly is most likely a postpartum, disorders. There is a whole set of postpartum or pregnancy-related mental health disorders that occur. Postpartum depression is the commonest. Postpartum blues occurs at very high rates. Postpartum depression occurs in a subset of these people. There is a propensity because, and again, there is a biological basis for this. This is not because of just, again, psychological, or a traumatic experience. It is that because of the hormonal levels drastically changing, from the period of pregnancy to the post-pregnancy period, there can actually be those sudden changes in all those hormones, the sudden drop and the increase in change that occurs leads to actually modulation again of the HPA axis, leading to estrogen interacting with various other hormones, stress hormones, and actually influencing the brain networks again, and leading to a development of a depressive state or a mood state that is likely to be associated with possibly suicidality in a certain subset.
Thank you, sir. I think I think it's almost time. If you don't have any other doubts, maybe you can wind up the session. Ravi Kumar, sir.
Yeah. Thank you, Dr. Senthil and Dr. Gokul Raj, for a wonderful session on suicidal prevention and other things. I think you have answered almost all the questions. So thank you very much. And we look forward to the next session in the next 15 days' time. Thank you very much once again.
Welcome, sir. It was a pleasure. And thank you so much for having me once again.